Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
Well, Dr. Paul, guess what? This is episode number 71. We've done this over 70 times.
It's been a pleasure, Terry.
I was going to say, aren't you tired of talking to me?
Terry, am I the only friend you have?
Yeah, you're like my imaginary phone friend. Hey, so we're back here with another episode of the CGM Doctor / Metabolic MD. You have both websites out there, so if you're ever looking for great information on metabolic health or how to use your CGM or get information about CGM, make sure you check out Dr. Paul's websites. So beyond the CGM and metabolic health thing, you are also an emergency room doc, correct?
That is correct.
So we're going to talk a little bit about some things that go on in the emergency room. And one of them you were kind of sharing with me a little earlier is people sometimes will come in with, maybe they're not physical issues, but they're psychological issues. Right. And what do you do in that case?
So, first of all, I thought we would talk a little bit more about emergency department cases just because we've talked about this a little bit and we're getting a good response. People seem to be interested in what goes on in the emergency department. And then, as sometimes happens in the winter, I had a few shifts over the last few weeks which were pretty heavy in psychiatric and alcohol-related problems. And so I thought I would share a little bit of, what happens in the emergency department when somebody comes in with a psychiatric issue and also with an alcohol issue and, how that's managed. How does the emergency physician and the emergency staff approach that?
All right. Well, my first question is, how do you even know you have one of those? Somebody's walking in the door and they're acting differently or acting a little bit?
Well, they usually come in or are brought in by family members with that issue.
Oh, really? They're not walking in themselves?
Yeah, sometimes, once in a while they are, but a lot of times they are in with family members, or sometimes law enforcement will bring them in. In fact, I had a case this last week we'll talk about. But with psychiatric issues, the two big issues that we worry about, the life threats are what's called suicidal ideation or homicidal ideation. In other words, somebody is thinking about hurting themselves,
right?
Or somebody is thinking about hurting somebody else. And so intervention there is important because the last thing you want to do is not take that seriously and have a person go out and have something happen to them or somebody they know.
My gosh, I never thought about that.
Yeah,
okay.
So the term we use is suicidal ideation, homicidal ideation, or SIHI. So
make sure I got this right, because maybe in my mind I was thinking the cops come, there's an issue, they put handcuffs on you, they take you away. I thought they took you to jail. They don't? They take you to the hospital?
Well, if you're suicidal, they will bring you in for evaluation. And this is actually the crux of the case that I was going to get to. It's interesting, and based on a single case, every time you got to take every patient seriously because you can't put their life at risk. But a case I had in the last couple of weeks, which is not an unusual scenario, is a patient or a person is arrested, and then after they are arrested, they become suicidal.
So they put them in the confinement, and then all of a sudden they freaks them out.
Well, or they suggest that they now want to hurt themselves.
Is that? Make sure you use the right word. Are they faking it to get out of jail?
So first of all, you can never assume that. You've got to take every presentation seriously.
Okay.
But it does cross. Just to be honest, it does cross emergency physicians and emergency staff's mind that the option for a bed in the hospital on a psych ward is maybe a better option for an individual than being incarcerated.
Oh, yeah.
Because a lot of times also the police will, they won't follow up. They don't I shouldn't incriminate them in that way. But sometimes the follow-up is difficult if the patient gets admitted to the hospital, so the person never gets arrested, really. And so, people sometimes become suicidal after they get arrested. And I had this case just this last week. And, of course, what we do is we take it very seriously. We treat them as a true suicidal ideation. You cannot assume in any way that they're, quote, faking it. But it does seem to happen not infrequently.
And is that a 3-day lockdown? They can't do anything? You're not allowed to leave for 3 days?
This is one of the topics we were going to talk about. People get what's called pink slipped. Have you ever heard that term?
No, not in the term of this, but I've heard it from work point of views.
Yeah, pink slipped in the emergency department means that a medical provider or the police attest that this patient is a risk for themselves, and then that means then at that point you can retain them against their will because they're potentially a threat to themselves or others.
And you don't need a lawyer or a judge to issue that?
It's a short-term thing.
Yeah.
It's generally a 48-hour hold, which can be reversed by a judge upon review. But the medical providers and the police have the authority to go ahead and hold the patient until they sort things out. So basically, it's kind of a first do no harm thing. If you're going to make a mistake on the side of protecting the patient.
Oh, that makes sense. Okay.
Yeah. So the other psychiatric presentations we see are depression, and of course depression is intertwined with the suicidal.
And what are some of the key signs of that?
With people that are depressed?
Yeah.
Yeah. I mean, a lot of inactivity, poor eating, poor sleeping. Usually these patients come in with some history of depression in the past.
And what are the questions you might ask somebody to kind of help guide you that this might be a depression issue?
Well, I mean, this isn't rocket science. You sit down and talk to people.
Yeah.
You know, what's going on in your life? What are the problems? What are the issues? But I will tell you, we're always driving at the point if this patient is at risk for themselves. Could they hurt themselves? We ask things like, have you had a plan to hurt yourself? You know, because a person that has a plan, I'm going to walk out into traffic. I'm going to drive my car into a brick wall.
Do they tell you that? I mean, you'd think somebody wants to do that, they wouldn't tell you that.
No, sometimes you're able to connect with people pretty well.
Okay.
And they will share things with you. Another key question, do you have guns in your home?
Oh, yeah.
Yeah, because guns are, of course, one of the most lethal mechanisms. And then there are certain categories of people that are at higher risk. For example, older men are at much higher risk for actually following through with a suicidal thought. Yeah.
Well, is there a reason why?
I think just, you know how men are. Men aren't as smart as women sometimes related to what's going on with life. But I think a lot of times they're older. Sometimes they're alone. They accomplish things when they were younger. They feel they aren't of value anymore. So they're at high risk.
Okay.
Obviously, if they're alcohol, in particular alcohol, but alcohol or drugs involved, that puts them at risk. And then another type of presentation is just anxiety, where people are just so anxious they have difficulty sleeping, etc. So I don't want to minimize anxiety, but usually anxiety can be managed with medications for a temporary period of time and then outpatient management.
What's a medication you might give somebody for anxiety? That would be something you'd give as an emergency room doc.
Yeah, so this is something we're going to get into a little bit when we talk about alcohol and medication detox. But there are some standard medicines like Prozac that can be used, Zoloft, which are the SSRI medications. The problem with those is they take a number of weeks to kick in.
Yeah.
There are medications that can provide mild sedation. An example of that are actually some of the stronger antihistamines, like one called hydroxyzine.
Really?
Sometimes help people, just settle down. And
is that stuff over the counter, or is it got to be prescribed?
That one, these have to be prescribed.
Okay.
There are some medications that impact what's called the autonomic nervous system, like the part of your nervous system that increases your blood pressure and makes your heart rate go up. You can sometimes use medications that will just calm and slow people down. So they're really often used as heart medications or blood pressure medications, but they can kind of cool people down so that they can get a night's sleep.
Now, if somebody walks into, somebody's brought into the ER with anxiety, are there questions you ask about that differently than depression, or what?
Yeah, quite honestly, it always comes back to the life threats that we opened with. Is there a risk of suicide or is there a risk of homicide? So basically then people go into two buckets, which is they got to be admitted to the hospital to protect themselves, or this can be managed as an outpatient with close follow-up in a clinic and maybe with some medications.
All right. So I know we want to get to the alcohol side of things before this podcast, and so how do we bridge our way to that?
Well, there's often a lot of similar components in these presentations. Patients with alcohol issues often have depression, and depression people often drink. So there is, a commonality among them. But a lot of times people will come in. The typical presentation for somebody, presentation means what they're complaining of or what they want when they come in, is people come in requesting detox. The term is, and I'm doing air quotes now when I say detox.
Right.
So it basically means that they want to get off alcohol.
Are they coming in on their own? Are they coming in, somebody's bringing them in? Are the police bringing them in most cases?
Yeah, all of the above.
All the above?
Yeah.
Okay.
Sometimes people will say, I got to do something. I got to make a change. Sometimes a family member says something needs to change here. Yeah. And, sometimes they're out getting in trouble and they're intoxicated. They've done things probably because they're intoxicated. And so you see all different kind of presentations.
But the old school way of it, my brother was an alcoholic, and the old school way was try not to drink.
Yeah.
Right. But I think there's new things out there, correct?
There are new things. You're jumping ahead, but let's.
I like to go to the last chapter of the book.
I know. We'll come back to some other things, but yeah, and I'm board certified in emergency medicine, but also in addiction medicine and preventive medicine.
Right.
So in addiction medicine, I've been working with alcohol patients for many years, using medications, and we should be using medications for many alcohol patients. And I use a medication called naltrexone.
And how long's that been around?
It's been around for 20 years or more.
Okay.
Yeah. There's a shot form called withdrawal, which is a once-monthly shot that decreases alcohol cravings. I have a tendency to use naltrexone, which is an oral medication which can be taken daily. But the way I like to use it is to give it to people on days they drink. Hopefully they aren't drinking every day. And so what this does is it kind of mutes the dopamine and the serotonin receptors in your brain. So when you're drinking alcohol, you take an naltrexone before you drink alcohol, and you don't get as warm and fuzzy a feeling as you would otherwise when you drink alcohol. And then on days you don't drink, you don't take the naltrexone, and I encourage patients to do something that's enjoyable. Take the dog for a walk, work out, whatever you enjoy doing. And then so those dopamine and serotonin receptors are getting stimulated on days they aren't drinking. They're being muted down on days that they are drinking, and over time the brain learns that you don't need alcohol every day. Now we integrate this with all kinds of techniques of goal setting techniques, like, okay, I'm going to have this much alcohol in the house. Okay, we're going to look at drinking maybe 3 days a week instead of 5 days a week. We're going to look at maybe making the maximum drinks in any setting, 3 or 4 drinks, not 8 drinks. So you put it together with all these other behavioral things, and people can make remarkable progress. And I think the medication can be very helpful in that regard.
Now, I know you're eventually going to get there in the last minutes of this podcast about semaglutides, how that has been used or has starting to be used to also help folks with alcohol issues.
Yeah, so there's not an indication for semaglutide or the other GLP-1s yet related to that. But I will tell you, in the patients on the metabolic health side that I treat with one of the GLP-1s, almost universally they drink less. And these are not necessarily people that drank a lot to begin with.
Right.
But there are some patients I've had that did drink a lot more than they wanted to begin with. And whether it's just related to the direct appetite suppressant effect, but I think the GLP-1 medications, I think in the next 5 years, will be approved for alcohol use disorder and will probably be the best drug that has come along since naltrexone to help people control their drinking. So I'm very optimistic about that.
You know, the thing when you describe is it naltrexone? Is that how you pronounce it?
Naltrexone.
Naltrexone.
Yeah.
That it kind of works to make you not want to drink because you took your dog for a walk and you felt good doing that, and then the other one makes you feel less good, right?
Yeah.
You remember the movie Clockwork Orange?
I remember. I mean, it's been a lot of Stanley Kubrick, right?
Yeah, and they had his eyes peeled back where he couldn't shut them, and they showed him movies of stuff, and it made him to where he didn't want to do it anymore, and it was kind of reminding me of that.
Yeah, it's a type of desensitization therapy. Yeah.
So anything left we want to talk about?
Well, just when people, I did want to talk about when people come in with an alcohol problem, intoxicated or not. Often the expectation is, well, I want to quit drinking alcohol. I want to get admitted to the hospital. But the patients that get admitted to the hospital for detox are the patients that are at risk for, withdrawing from alcohol seriously. So you admit patients that are at risk for what's called complicated withdrawal. So complicated withdrawal is we have delirium tremens, which means they're uncontrollable shaking, not just a little tremor, but uncontrollable shaking.
They have this. This is
these are the people that you got to admit to the hospital
because cold turkey will cause these issues.
Like alcohol withdrawal, of course, can be life-threatening.
I didn't know that.
Oh, absolutely. Delirium tremens. Hallucinations, people that are having hallucinations during alcohol withdrawal, or of course people that have seizures. Those are the three primary criteria for complicated alcohol withdrawal, and those people can get admitted to the hospital. Now, if you don't have a history of that, or if you're judged clinically not to have a history of that, then you're unlikely to get admitted to the hospital acutely. So those are the patients that go into the category of getting set up for outpatient management. And I'll tell you, that's often a dissatisfier for patients and family members where, they come in and something's got to be done. The drinking's out of control. There's no history of complicated withdrawal. And so they go into the bucket of, we're going to set you up for outpatient management, which really isn't what they wanted.
I could see that.
As opposed to being admitted to the hospital. And, in the old days, 30, 40 years ago, before we got as serious about managing a complicated alcohol withdrawal, you're going to find this unbelievable, but it was true many years ago. What do you think the treatment was for somebody that might have a history of complicated withdrawal, but there was no room in the hospital or they weren't going to get admitted to the hospital? It was to go home and do what?
Drink coffee?
No. Continue to drink alcohol.
What?
Yes. It's craziness. But it was like, if you wanted to avoid bad withdrawal, how do you avoid bad withdrawal? Well, you feel you're having shakiness, you feel you're at risk, then just you drink a beer, but make sure you get to your follow-up appointment in a couple of days. So that's literally what had happened in some locales and in some facilities 20 years ago. I do think that we're beyond that now, but I wanted to explain to people this is why some people will get admitted to the hospital for detox, and while other people were managed as outpatients. And the one thing I want to mention is alcohol withdrawal is life-threatening. The other life-threatening substance use that exists is benzodiazepines. So benzodiazepines are the Ativans and the Xanaxes and the Valium medications, often used for anxiety. But withdrawal from those medications can be life-threatening.
I didn't know that.
Yeah. And then the kicker is that opiates, which have got all the press over the course of the last 15 years,
right.
Opiate withdrawal is not life-threatening. People don't die from opiate withdrawal.
Why is it so hard to get off of?
They're just because they're so addictive. Because the withdrawal symptoms are bad, but they aren't life-threatening.
Oh, wow. I didn't know.
So the phrase that's used, and I don't mean to be trite about this, but the phrase that's used is, benzodiazepine withdrawal and alcohol withdrawal will kill you. Opiate withdrawal won't kill you, but you're going to feel like you're going to die.
Wow.
So
the last question I have for you, out of 100 people that come to the ER on a period of time, how many are coming in with some type of alcohol or depression or something like that it's not necessarily something that normal, as a doc you would treat, but it goes to a psychologist kind of thing?
Well, you mean that coming in with a psychiatric or substance use issue as opposed to a true medical issue?
Correct. How many out of 100?
Yeah, 15, 20 or so.
Oh, really?
Yeah.
That's a lot higher than I thought.
Now, I work at a VA hospital, so that patient,
It's gonna be higher.
It's a little bit higher.
Yeah.
And would be lower in a community hospital setting, but it's a significant portion of our work.
Well, we're going to have to end it here because we just reached our time limit.
All right.
And we're going to come back here real soon for another podcast with a Metabolic MD / CGM doctor, Dr. Paul Kolodzik. I'm Terry O'Brien, your producer, and we'll see you guys again real soon.